Welcome to today's lesson where we're going to be discussing different components of the urinalysis, and we're going to go through these components here briefly, but at least you'll get an idea of how to use the urinalysis when you're examining someone's urine. What we'll do is we'll start from the bottom and work our way up because it's a little bit easier from the bottom. And so the first part are crystals. And crystals are easily identifiable because they have certain types of features. All crystals generally have sharp edges, so they're not going to be rounded edges like what you'd see with epithelial cells or even casts or white blood cells. And depending on the type of light that your microscope emits, they may scintillate or sparkle. Now, having an occasional crystal in your urine is not unusual, but you need to have many crystals in the urine in order to say you have crystalluria. So you need to have a urine analysis that shows a high quantity of crystals in order to be considered pathologic. And finally, one point you need to remember about crystals in the urine is that if you collect urine from a patient and store it in ice before you examine it in the microscope or send it down to the lab, you can precipitate crystal formation. So be sure to store your urine at room temperature before you look at it in the microscope or send it for examination, because if you store it at a cool temperature, you could precipitate crystals and falsely assume that the patient has crystalluria when the patient doesn't. So that's crystals. And now we'll talk about casts. Let's erase all this. So casts take on the shape of the tubule. So they usually look like this, or sometimes like this. And there are many different, or some variation. There are many different types of casts. You have hyaline casts, white blood cell casts, red blood cell casts. The most common, which would be muddy brown casts. You have granular casts, which are sometimes even subdivided into fine and coarse. And you have broad waxy casts. Probably the most common cast you'll find in patients who have normal function or borderline damage are the hyaline casts. These are casts that generally take on one of these two shapes or some variation of these two shapes. They don't have any intracast components, so you're not going to see cells in these casts. You'll just see very light material. And what characterizes hyaline casts predominantly is that they're very faint. They're actually a little hard to see if you're not looking for them. What are they accurate for? What do they really represent? They could just be some epithelial cells that line the tubule that have sloughed off, but not necessarily pathologic. So these are considered benign casts. Then you have cellular casts, which are here. White blood cells, red blood cells, and sometimes the muddy brown cast. So white blood cell casts take on one of these shapes for the most part, and they have cellular elements inside. And you should be able to make out these cellular elements. And you should be able to tell that these are white blood cells because they have nuclei, which will be pretty predominant. Red blood cell casts also take on one of these shapes, and they also have cellular elements inside the cast, but these cells don't have nuclei. And that's one of the main ways of telling or differentiating between a white blood cell and a red blood cell cast. Keep in mind that some red blood cell casts, even though their red blood cells don't look red, they look lightish brown or tan in color, sometimes golden in color. And that's why red blood cell casts are commonly confused with muddy brown casts. Now, a true muddy brown cast really looks dark brown, and you really can't tell or differentiate any cellular elements on the inside because it's just sloughed off epithelial cells from the tubular structure. However, The color of some muddy brown casts can be light brown or light tan, and that can be confused with the red blood cell cast. And so the best way to tell the difference is to look at the components in the cast itself. The muddy brown cast will have an amorphous type appearance within the cast, and the red blood cell cast will actually have cellular elements inside of it. Then you have the granular casts, and granular casts look a little bit like muddy brown casts, except they're light golden color. They can be fine if the granules inside are very fine, or coarse if the granules inside are coarse. They do represent some pathology. They may represent some early acute tubular necrosis. You may have granular casts and check the urine again in 24 hours and learn that now you have muddy brown casts and that the granular casts were a precursor to ATN. So these are sometimes considered pathologic. We know muddy brown casts are pathologic. They represent usually ATN. Red blood cell casts are pathologic. They usually represent a glomerulonephritis. And white blood cell casts are usually pathologic. They represent, at the minimum, an interstitial nephritis. And then you have broad waxy casts, which look a little bit different. And they look like this. They can take on a curved appearance or a more rectangular appearance, but what's key about them is they have these indentations in here. They're not specific for any particular pathologic disease, but they do indicate some sort of chronic kidney disease of any etiology. So one would say if there's a predominance of broad waxy casts, you probably have some kind of pathology, but not specific enough to tell you what type of pathology you have. So those are casts. Along the same lines, you have white blood cells and red blood cells, so we can go over that briefly. As I told you before, white blood cells have a nuclei, so you'll be able to see the nucleus under the microscope. They usually take on a circular appearance, but they have some elements within. Red blood cells, despite being called red blood cells, don't look red on urine microscopy. They're usually clear, oval shaped in color. So this is what a white blood cell would typically look like. This is what red blood cells would typically look like. There'd be nothing inside the red blood cell. They'd be very small. Usually the cell that is the smallest on a urine microscopy slide is the red blood cell. So you can see the difference in size, and actually one way of determining whether you have a white blood cell is to find a nearby red blood cell and compare the sizes. The white blood cell should be significantly larger than the red blood cell. In addition, the white blood cell should have elements within the cell itself, like the nuclei, and the red blood cell should be pretty empty. So that's the red blood cell and the white blood cell. Now let's talk about blood. Blood is actually one of the few misconceptions in the urinalysis, because when you test for blood, you're doing a qualitative test and you're looking at the color change on your urine dipstick. If it changes a certain color, it will tell you how much blood you have, anywhere from no blood up to 3+ blood. The problem with the blood part of the dipstick is that it's not measuring hemoglobin, it's measuring any pigment. And that's where things get tricky, because if you have pigments such as myoglobin, you will get a positive result in the blood component of the urinalysis, but you don't have any red blood cells. So the best way to look at blood is to think of blood as a pigment. And if it's positive, 1+, 2+, or 3+, there's some pigment in the urine. It could be hemoglobin, but it could also be myoglobin. Easiest way to differentiate between hemoglobin or myoglobin causing a positive blood reaction on the dipstick is to look for red blood cells. If you see red blood cells on your urine dipstick, then you can be pretty sure that the pigment that's being picked up is hemoglobin. If you don't see red blood cells, then you can be sure that the pigment is something other than hemoglobin. One of the most common ones is myoglobin. So blood and red blood cells should be grouped together. You should never look at these in isolation. You should certainly not look at blood in isolation, because you can be easily fooled into thinking you have hemoglobin when there's another pigment. So then we have glucose, and glucose is interesting because there's only two main ways you would have glycosuria or glucose in the urine. A true glycosuria is one where you have tremendous amounts of serum glucose, and that glucose is filtered through the glomerulus, and only a portion of that glucose is reabsorbed by the proximal tubule. The remaining glucose that exits the proximal tubule is what you collect in your urine and what gives you the positive glucose result. So that's called true glycosuria. You also have a false glycosuria. That's when you have glucose in the urine, but you don't have a high serum glucose. You have a normal serum glucose. So the problem that you actually have is not that you are overwhelming the proximal tubule with all this glucose, but you have a proximal tubule that's defective. So false glycosuria is usually a situation where you have normal serum glucose, but you have positive glucose on your urine test, and it's an indication of proximal tubular dysfunction. And one of the most common examples that students and residents learn about is the Fanconi syndrome. But any kind of damage to the proximal tubule due to multiple myeloma, due to heavy metal toxicity, maybe even some autoimmune disorders, will give you some amount of glycosuria that's considered false because your serum glucose is normal. So that's glucosuria. Now let's look at nitrite and leukesterase, because these are pretty simple. They usually go together. These are common outpatient tests that we do to determine if someone has a urinary tract infection, because bacteria will usually release these two components. So there's really nothing more to talk about than the fact that if it's positive, it might suggest you have a urinary tract infection, and if it's negative, it might suggest you don't. But of course, the sensitivity and specificity for both of these tests is somewhat poor, so you'd need to confirm with a urine culture or even a microscopic analysis to look for bacteria floating around. Bilirubin, so as you know, it's direct bilirubin that is excreted through the urine. And the greater amount of bilirubin that's excreted, the more yellow your urine is. Of course, your urine can also be yellow if you have limited amount of water being excreted, say you're dehydrated or hypovolemic. But generally speaking, a person who's well hydrated, drinking normal amounts of water, who has very yellow urine, probably has that because they're excreting a lot of direct bilirubin. And you will have to evaluate that person for hemolysis or some kind of gallbladder or liver pathology to determine if this direct bilirubinemia, or bilirubinuria, is truly pathologic. And now we get to the three, what I would consider the three most important parts of the urinalysis, and probably the three most confusing. We'll start with pH first. Now the pH that you get on a dipstick usually ranges from 5 to 8 and increases in intervals of 0.5. What's misleading about the pH is that although you get a number, a quantitative value, the urinalysis pH is actually a qualitative test. It's a color test. The color on the urine dipstick changes approximately based on the pH of the urine. You're not getting an accurate pH. And why is that important? Because there are certain disorders like kidney stones or renal tubular acidoses, when you actually need to know what the quantitative pH is. So you won't be able to rely on a urinalysis to get this information. You'll actually have to ask the laboratory to perform a quantitative pH measurement, because you have a condition where things are more likely to develop if you have a low pH in the case of kidney stones, or you want to confirm whether someone has a renal tubular acidosis. So just keep in mind that the pH on the urinalysis is more qualitative than quantitative, gives you a rough idea of how acidic the urine is, but is certainly not going to be useful when you have pathology that's pH dependent. The next is proteinuria, and this is another misnomer because many urinalysis testing doesn't test for protein in the urine per se, but they test for one particular protein, and that's albumin. So what I like to do when I see positive proteinuria, and of course this ranges from 0, 1+, 2+, 3 plus, and 4 plus. What I like to say is if there's 3 plus proteinuria, I convert that in my mind to say 3 plus albuminuria. Now there's 4 types of proteinuria that we need to go over because the dipstick will really only help us out with one of them. Glomerular proteinuria versus the other 3. Tissue, overflow, and tubular. Glomerular proteinuria is what the urinalysis is designed to pick up because most of the time when you have damage to the glomerulus, the protein that leaks out is albumin. And that's why these tests, like the urinalysis that we typically use in the office or in the hospital, generally measure albumin in the urine. But there are other types of protein like beta-2 microglobulin, immunoglobulins, etc. that can leak into the urine and give you a false reading on your urinalysis. Tissue proteinuria is common when you have damage to the tissues, say from radiation therapy or cystitis due to a bacterial infection. Overflow proteinuria is common when you have a plasma cell dyscrasia like multiple myeloma, or just a rip-roaring infection, where you have so many proteins being filtered through the glomerulus that the proximal tubule cannot reabsorb all of them, and some of them spill out. And tubular proteinuria occurs when you have damage to the tubules, like acute tubular necrosis. In this case, you have lots of protein that are not being filtered into the urine, but secreted and released into the urine because the tubular foundation and structure has been damaged. So you want to use your urinalysis to determine if you have glomerular etiology of proteinuria or some other etiology of proteinuria, because this is an indication of actual disease in the glomerulus, and this is an indication of perhaps disease outside the glomerulus and not necessarily a glomerulonephritis. So that's proteinuria or albuminuria, which is a little bit more accurate when you're talking about the urinalysis. And the last thing is a specific gravity. The specific gravity is really a ratio of the density of urine over the density of water. So the density of water is considered 1. And we normally get urine or specific gravities that are in the range of 1.010 to about 1.020. So you can see that the density of urine is just slightly greater than the density of water. And that's because you have things in the urine that you don't have in the water, like sodium and potassium and chloride and protons. But more importantly, cells that slough off from the tubules just in the normal course of renal function. Some protein that is leaked out that may not necessarily indicate pathology. So cells, or we'll say some cast, and depending on how you store your urine, you may even have some crystals that are not necessarily pathologic, but may have developed because you stored your urine in a cold environment. So these things can help increase the density of urine. But if you have specific gravity that's very, very high, say 1.030 or even higher, it suggests that one of two things. Either you don't have a lot of water in your urine, and for some reason you're not excreting the proper amount of water, say you're dehydrated, or you have a pathologic condition, or you have a lot of things in your urine that normally shouldn't be there. Say you have a pathologic condition like ATN, and you have many epithelial cells being sloughed off, or you have glomerulonephritis, and you have lots of red blood cells and red blood cell casts that are entering into the urinary space. Those will increase your specific gravity as well. So using the specific gravity, although it's not very accurate, gives you a quick understanding of whether there's some kind of pathology in the urine or not, in the kidney or not, based on the value that you get. And so that's the main components of the urinalysis. Thank you very much.